Yes, yes.
Yes, Bhupesh.
Okay. So here all IMA members on behalf of Medical Association Vadodara, Secretary, welcomes you all on this beautiful day. Today it is 2/2/2022, and on such a beautiful day, we all will be having on such an important topic which touches our day-to-day life, mainly vaccination. Vaccination of most important working force of our country, that is adolescents and adults. So, dear friends, please listen it carefully. If you have any doubts today, you can ask your doubts into the chat box given itself. And now we are starting as per the protocol. First with IMA prayer. May everybody be happy. May every one of us see to it that nobody suffers from any pain or sorrow. I do not ask, nor I wish to be in heaven or reborn. I only want to alleviate the suffering of those people who are burning in fire of sorrow. I am a flag salutation. We, the members of Indian Medical Association, stand here to salute our national flag. Its honor and glory shall be our light and strength, and its course shall be our course. We pledge our allegiance to it and realizing our responsibilities as the accredited members of this national organization. Here we will dedicate everything in our power to see it fly high in the committee of nations. Jai Hind, Jai IMA. So, dear friends, herewith I want to thank IMA President Dr. Mitesh Shah, who suggested us that this topic we must include into our webinar activity. Then also I thank Vadodara Adolescent Health Academy President Dr. Samir Shah, Secretary Dr. Hitesh Vasa, my friend. Then AOPV, Academy of Pediatrics Vadodara, President Dr. Asutosh Singh Rathod, Secretary Dr. Bhavish Kanabara, for helping me in organizing today's CME on such a large platform to bring awareness about adolescent and adult immunization. I also extend my thanks to DigiShield for providing us technical support for today's CME. And dear friends, please note that we will be using this platform for a few more CMEs of IMA that touches nearly everyone, because it will we will be discussing about fire and BU, that is building utilization certification and all. And the speaker will be the fire officer himself, Mr. Parth Trumpet. So this will be a really fruitful CME, because by this platform we all can connect on a digital platform only by sitting into our drawing room itself. And with this platform we can reach much more IMA members. So it will be announced very soon in the near future. Then regarding today's CME, dear friends, whatever questions arises into your mind, please type into the chat box. And into the end, Dr. Samir Shah and Dr. Asutosh Singh Rathod will be asking the questions to our speaker of today, that is Dr. Satish Pandya. So let me introduce our today's speaker, who is a very senior pediatrician par excellence. He is not only pediatrician but also a counselor, doing his practice at Varun Complete Healthcare, Vadodara. He is a past IAP National Vice President West Zone. He is past President of Academy of Pediatrics and National Neonatology Forum Gujarat Chapter. He is past National Chairperson of Computer Chapter of Indian Academy of Pediatrics, National Trainer and Faculty for several IP modules, has contributed many chapters and articles to the books and journals, and his areas of interest are infectious disease, vaccinology, counseling, computers in clinical practice, adolescent medicine, and promotion of rational therapy. So I welcome Dr. Satish Pandya. Please share your knowledge about today's very important topic, that is adolescent and adult immunization. The stage is yours. Thank you, sir. I'm stopping my slide.
Yes, yes. So thank you, Dr. Bhupendra. And I also, at the outset, thank IMA Office Bearers President, Dr. Mitesh, Scientific Secretary, Dr. Neeraj, and our WAHA friends, Dr. Samir, Dr. Hitesh, and AOPU friend, Dr. Asutosh, and Bhavik. So it's a great opportunity to be with you all, talking about something which is very dear to all of us, not only pediatricians, but this after COVID pandemic, almost whole community, the medical community as well as non-communal, non-medical community, they are all involved in this topic about vaccinology. So it's a good opportunity for me to share my thoughts on very important topic, and that is adult and adolescent immunization. Is my screen visible?
Yes, sir.
Okay. So let us start with, we are all clinicians. So let us start with, and I believe, I guess all the audience consists of heterogeneous audience. Like say, there may be pediatrician, there may be family physician, and there may be physicians also. So we are all clinicians. Let us start with some case scenario. Like a 16-year-old boy gets chickenpox during board exam and misses it. We have a 21-year-old female who delivers a child with congenital cataract, microcephaly, intrauterine growth retardation, and whatnot. A 60-year-old lady is diagnosed with advanced cancer cervix and asks, doctor, could this have been prevented? A 24-year-old young man gets an important interview call for a very lucrative job and is hospitalized with entry fever and is sad for the missed opportunity. A 70-year-old succumbs to pneumonia. So friends, can we prevent these sad stories? The answer is yes. The answer is in adolescent and adult immunization. So today we'll cover following points. First will be introduction as to why we are talking about adolescent and adult immunization. We'll have an overview of all relevant vaccines, the disease burden and available vaccines and age-related schedules, and summary of recommendations. Friends, we will not discuss minute details of each vaccine, which is out of the scope for today's talk. And of course, we will not discuss COVID vaccines. They are discussed a lot and they require a lot of time to discuss them. So today we'll be focusing mainly on adolescent and adult immunization with other routine vaccines. So is it because of COVID that we are talking about adult and adolescent immunization? The answer is both no and yes. The answer is no, because COVID or no COVID, adolescents were being given vaccines before COVID also, and adults were also receiving few vaccines like tetanus toxoid, HPV, flu, and pneumococcal vaccine. And WHO, which gives a theme every year in 2019, the theme was vaccine works for all. So COVID or no COVID, we did talk about immunization of adults and adolescents. But to an extent, the answer is yes, because COVID has made a significant impact in the field of vaccinology, not related to only COVID vaccines, but bringing in awareness. So in a way, COVID has come as a blessing to this field, because there is an advent of awareness. Like people talk, like say lay press talk, community people talk about vaccine trials, phases of trials, sample size, virology, vaccine efficacy, herd immunity, adverse events following immunization, antibodies, T-cell immunity, and so on and so forth. So everybody is talking about vaccine now, and the community has become a witness to the immense benefit of vaccine. From the recent example of COVID, we all read every day in the newspaper that those who are vaccinated are well protected against not disease, but against at least severity of the disease and mortality due to disease. So people have become aware about vaccines. We as pediatricians, we deal with parents and they are mostly aware about childhood vaccinations. But somehow adolescent and adult immunization is not much of a point of discussion amongst the community as well as among the medical fraternity also. Immunization is essentially an evolving science. It is one of the most important scientific advances to fight infections. Nobody will dispute it, because where would have been we have been if smallpox was not vaccine was not invented, if polio vaccine was not there, what would have happened? We have seen the spectacular success stories of both smallpox and polio. When we were studying some 35, 40 years back, when I was doing my MD, there are only 6 diseases against which we had vaccines, like say TB, polio, tetanus, pertussis, diphtheria, and measles. And now we have traveled a long way. Now we have vaccines against rubella, mumps, hepatitis B, meningitis, viral diarrhea, pneumonia, otitis media, enteric fever, cholera, yellow fever, Japanese encephalitis, and so on. It's a long list of vaccine preventable diseases. So look at this schedule of IAP. This is the schedule we use for young children. And look at this left column, where there is a list of the diseases against which we can now give vaccines. So they are about 20, 21 in number, and this is the column where we use this schedule to vaccinate children up to the age of 18 years. There is a change in the age spectrum where no vaccines are available. The reason is because immunization is no longer limited to young children, and non-communicable diseases like certain malignancies also can be prevented with vaccines. And there are additional beneficiaries apart from the young children which we are vaccinating earlier. Now we have adolescent and young adults, that is AYA, India's demographic dividend, which is 10 to 24 years of age, very productive age, very formative age, and which they form a very large chunk of our population. And in adults, there is increased longevity. There are a lot of comorbidities which are predisposing to infection. So we need to have a change in the spectrum of immunization. So why do we need to vaccinate adolescents and adults? Because there are people who have missed some vaccines during their childhood. And most important thing is the waning of immunity. We hear a lot about waning of immunity with COVID vaccines. So there are vaccines in childhood also where we do see waning of immunity with measles, varicella, pertussis, tetanus, diphtheria. And there are people in some age groups who were born much before the advent of these vaccines. They may not have ever received this vaccine. So because vaccines were not available. So there is a large group of adolescents and adults who need immunization for the missed opportunities or when they did not have the vaccine during their lifetime, early lifetime. There is also a reason because there is a shift in epidemiology. Epidemiology is shifting regarding certain diseases. What we are seeing in only childhood is now seen more often than earlier we thought in the age group of adolescents and adults also. As we will go through some of the slides where I quoted some surveys and studies where we are seeing a lot of this so-called childhood disease in adults as well as adolescents. And there is a high incidence during adolescent period, like say mumps, meningococcal disease, we see more often in adolescents. And in the older age group and adolescents, we see high morbidity and severity of disease like varicella and hepatitis A. Also, to prevent certain adulthood cancer like cervical cancer and liver carcinoma, now the vaccines are available. And there are high-risk adults who have a lot of comorbidities and those who are on immunosuppressive medications or whose conditions are themselves predisposing them to more infections. Extreme of age itself, the older you grow, the less immunity you develop. And it is said that there is 100 times more risk of dying than children with a vaccine preventable disease. If you take one particular example of say pneumonia, and if you take a young child and if you take a 70-year-old male, the chances of his dying because of this vaccine preventable disease is 100 times more. That's a huge, proportionately dangerous situation. And of course, global travel also contributes to a lot of infections in adults and adolescents. So if this is so important, the question is, why do we lack in adolescent and adult immunization? So there are certain barriers which prevent this approach of adolescent and adult immunization. Some of these factors are like say lack of awareness and knowledge gap across whole spectrum of stakeholders, be it healthcare providers, be the physicians or be the family doctors or others, consultants, the policymakers and the patients. Policymakers have their own priority, keeping the whole community in mind, and patients, our beneficiaries with whom we come in contact every day, and still we fail to impart awareness and knowledge about this need for immunization. And then there are limited opportunities for interaction with we as pediatricians, come often less frequent adolescent visits. So we also miss some of the opportunities for boostering or HPV like vaccines. We often miss because they stop coming to us once they grow up beyond 5-6 years of age. And of course, there are financial considerations as we go through this presentation. In the last, I have mentioned some costs of these vaccines. So that also is a consideration. Then lack of special adolescent clinics. Although IAP has been promoting adolescent medicine, some of us are trained in adolescent medicine. We do not have special adolescent clinics where an adolescent can walk in and get its specific exclusive vaccines meant for adolescents. Talking about adult physicians, if there are some physicians in the audience, they would agree with me that it comes as a no or even very low priority in their busy schedule. They are too busy with other pressing medical problems. And often I've seen my friends, they consider that that is not their domain. Immunization is not their domain. They would rather hand it over to someone else. And there is a lack of promotion also from industry as well as we as medical professionals. And of course, there are vaccine misinformation campaigns, anti-vaxxers who further discourage patients or parents accepting adolescent immunization or adult immunization. So the point of discussion, we have already talked about introduction, the need for adult and immunization, adult and adolescent immunization, and what are the barriers. Now let us have a look at all relevant vaccines which are being recommended for these age groups. We'll talk about the disease burden in short and available vaccines and their age-related schedules. And lastly, we'll have summary of recommendations. So these are some of the vaccines recommended for adolescents. These two, Tdap or TD and HPV are, I would say, exclusive adolescent vaccine. These are the must kind of vaccines for all adolescents. And there are certain vaccines which can be labeled as catch-up immunization because they were meant to be given in early childhood or late childhood, but somehow the children have missed that. So we can catch up with mumps, measles, rubella, varicella. We can catch up with hepatitis B, hepatitis A, and typhoid. And there is a third group that is a high risk or with endemicity regions or under certain special circumstances. We recommend these vaccines to adolescents like flu, pneumococcal vaccine, meningococcal vaccine, rabies, yellow fever, Japanese encephalitis, and cholera. And of course, since we have decided not to talk about COVID, but COVID for all, it's a universal recommendation for now adults. And we already started giving vaccines to 15 to 18 years of age group. Now, these are some of the vaccines for adults. Often physicians will wonder that what kind of vaccine can we offer to adults? So there is a simple answer to that. Routine vaccines which can be offered to adults is a pneumococcal vaccine, influenza vaccine, HPV, Tdap, and Jostler. There are certain catch-up immunization which can also happen in adulthood, like hepatitis B, hepatitis A, typhoid, MMR, varicella. We'll look at some of the age limits where till what time we can give this catch-up immunization. And of course, under special circumstances, we can offer Japanese encephalitis, yellow fever, rabies, and COVID for all. So let us talk about this TD or Tdap. What is this? T capital means full dose of antigen or toxoid in that, and D is for small d is for diphtheria in small dose, and small AP is acellular pertussis, small dose. As you know, in young children we give full TDP, that is full dose of diphtheria and pertussis also. And in pertussis we have two kind of vaccines, one with whole cell pertussis vaccine, that is WP, and other is acellular pertussis. So when we talk about adolescents and adults, we talk about small doses of diphtheria and pertussis. We cannot give the routine high dose that we give in children because of reactogenicity. So tetanus, we all know, is a potential perpetual threat. Any moment anybody gets any injury, the treating physician or a surgeon would always give a TT dose irrespective of whether the patient had taken previous TT or not. So it's a potential and perpetual threat of tetanus in our country. And there are some data. I have taken some data from recently published book. We do not have much data about adolescent and adult prevalence of the diseases as well as uses of the vaccines. So this refers to some survey in 2016. So it was reported that there are 3,781 cases in India. We as pediatricians mostly have stopped seeing tetanus, and you physicians also must have stopped seeing tetanus much, but the harsh reality is that tetanus still exists, and there were 227 cases of neonatal tetanus, and still we do see trickling incidence of neonatal tetanus still happening in India. In 2017, one sero survey in the age group 7 to 17 years old showed only 64% were immune. That is, the antibody response was detected only in 64. That means 36% probably did not have protection against tetanus. So similarly, in a survey of 21 to 30 years, it was 50%. 31 to 40 years, it was 30%, and above 40 years, 2.2. So there's a huge chunk of population which has probably never got any vaccine. Maybe there are these are not actually correlates of protection, but they do reflect the immunogenicity prevailing in our community. Similarly, for diphtheria, there are sporadic outbreaks. We often read in our newspapers in Gujarat also, especially in North Gujarat or Panchmahal, we often see outbreaks of diphtheria in children, and that also includes adults and adolescents also. So above 40 years also, cases of diphtheria have been reported. And there is a shift of epidemiology from young children to adolescents and adults. Unfortunately, India contributes to about 80 to 90% of world cases of diphtheria. I think we are the nation where not very proud to be leading leading nation which is seeing so many cases of diphtheria out of the whole world. And of course, with all these vaccines, as I said earlier, there is a waning of immunity. So there is a lack of protection against diphtheria, even if you have been vaccinated in early childhood with both primary and booster doses. In 2016, the same survey which I was talking about, 41% of cases were found in more than 10 years of age. So out of say 100 children who got diphtheria, 40 were more than 10 years of age. Again, a sero survey of children 6 to 17 years, protection was there only in 56%. In 30 to 50 years age group, sero protection was only 47%. All these data suggest that a large chunk of our population is unprotected, and we are sitting on a dangerous ticking bomb where an outbreak can involve a lot of people. So that is also a cause for concern, because diphtheria is a serious disease. Pertussis or whooping cough, again a very severe disease for young children and can happen with adults and adolescents also. Again, India contributes about 43% to the global cases. In India, excess incidence is not known, but adolescents do get it. And other problem with adults and adolescents is that they pass on the infection to the infants, and which is a very severe illness in young infants, causing even more mortality. Of course, there are not Indian much studies, but a sero survey of 8 Asian countries, including India, where a large number of patients were involved in the survey, the positivity was found only in 18%. That means 72% or 82% of the population was prone to pertussis. Few studies in adults suggest seronegativity up to 21%. Tdap gives limited protection. That's a sad fact of it. So although we talk about pertussis in adults and adolescents, sad part is that Tdap doesn't give a very strong immune protection to the person given. But still, considering all this data, we must consider Tdap in adults and adolescents. Another good thing is about maternal vaccination during pregnancy can protect the newborn very largely. And vaccination of people around an infant, which is known as a cocooning concept, is also one of the indications for giving Tdap. Tdap is a costly, as we will see later on, that it costs more, but TD is cost effective. So TD is one vaccine which can be offered to all adolescents and adults. So recommendation for Tdap or TD, I'm talking about both Tdap and TD because diphtheria can also be prevented with TD, and it's a very cheap vaccine, say about 20 rupees only, whereas Tdap costs more than 1,000 rupees. So previously not immunized with DTP, any adolescents or adult, 3 doses are recommended, 0, 1, 6 months. Preferably, the first dose should be Tdap, and then you can have TD. So 0, 1, and 6 months. If there was a previous immunization completed, then 1 dose of TDP at 10 years or catch up to 18 years. So all our children who have grown up with primary and secondary series of tetanus, diphtheria, and pertussis vaccine should always be offered 1 Tdap at 10 years of age and later on every 10 years. Pregnancy, Tdap 1 dose every pregnancy. So that is a recommendation, and it is, I think, being followed even in NIP also. They give TD, not TDP. Another vaccine which is very important in this age, both age groups is HPV. It's an adolescent-specific vaccine at the top of the priority list. After Tdap, we give priority to HPV. And I don't need to emphasize the fact that burden of cervical cancer is 25% of the global cervical cancer deaths. It's a huge amount of people who are, number of people who are dying because of cervical cancer. Incidence ratio for cervical cancer in India is 22.9. That's about 23 per 1 lakh women per year. Again, a very huge number. Every hour, I think, you may be seeing 1 or 2 cases of cervical cancer. It's included in the national immunization programs in more than 60 countries. Of course, we have not yet included. An attempt was made some time back, but then there is a setback there because of some, whatever the factors. I may not be able to discuss that, but it's included in the national immunization program in more than 60 countries around the world. So the schedule is age 9 to 45 years for valency 4 and 9. 2-valent is not available now. The cost is ranging from 3,600 for a 4-valent vaccine to 11,000 for a 9-valent vaccine, which has become available very recently. So the schedule is 2 doses, 0 and 6 months. Interval is 6 months. 15 years or more age, up to 45 years we can give. So there are 3 doses at 0, 2, and 6 months. And it is recently approved, especially the 9-valent vaccine is approved for males. Quadrivalent vaccine is approved in boys in other countries. Our authorities have not approved for males in our routine schedules, but the company has got an approval for males for 4-valent vaccine also. So mumps, measles, rubella, again, very common diseases. The serological susceptibility, I'm talking about adolescents and adults, is 9.5%, 32% for mumps, mumps, and 16.6% for rubella. So we are talking about these 2 diseases. Measles, by and large, because of the intense campaigns, we don't see much in adolescents and adults. So we talk about mumps and rubella. Mumps basically is a disease of school-going children, and we see a lot of outbreaks happening in schools, and we see series of a number of cases in a given time when the outbreak occurs. Again, the mumps immunity wanes fast after the primary series of booster and primary and secondary series of boosters. Rubella, all of you know, is dreaded for its complication of congenital rubella syndrome with so much disability and morbidity, as we saw in one of the cases where child has intrauterine growth retardation, mental retardation, congenital cataracts, and whatnot. So the MMR schedule for adolescents who have not received in past is 2 doses of MMR at 4 to 8 weeks interval. At present, 3 doses are given by 5 years of age. The 3rd dose, whether we should give in the adolescent period or not, is a question mark, presently not recommended. Maybe in the years to come, we'll give 1 more dose during adolescent period. But those who are not received, definitely, we give 2 doses of MMR at 4 to 8 weeks interval. And when there is an MR campaign mode, you must have noticed a couple of years back, we had a big campaign of giving measles and rubella to all children up to the age of 15 years. And of course, there are students now who go abroad for studies to countries who demand MMR. So we do have to give MMR to the students also. Chickenpox, there is a shift in epidemiology, and we see more now adults and adolescents getting chickenpox. This epidemiological shift may partly be because of the high rate of immunization. So in a community or in a nation where you see high coverage of immunization with these childhood diseases, there may be a shift, epidemiological shift of incidence in the older population. So the susceptibility to varicella is 20 to 30% for 11 to 20 years. That means 1/3 of the population is not protected. and it is more than almost 20% for more than 20 years of age. So outbreaks among adolescents and young adults are very common, not only common, but they are very severe. What we see in early childhood are less number of lesions, less toxemia, less sick look of the child. But when an adolescent or a young adult gets it, they are really, really very sick with high-grade fever and lot of lesions with all the complications associated with that. There is a hazard to fetus or newborn if someone gets it during the pregnancy. The recommendation is up to 2 years, 2 doses, minimum 3 months apart. About 12 years, you give 2 doses again, but the interval between 2 doses could be 4 weeks. And once you have noticed that there is a documented fast infection of chickenpox disease, there is no need to give vaccine because it gives a natural infection, gives lifelong immunity. Unlike some other diseases like say enteric fever, you don't get any lifelong immunity with enteric fever. Hepatitis B, there are classifications of various countries into the endemicity, and we fall in the category of intermediate endemicity for hepatitis B. The prevalence is 2 to 7%, a very high percentage of HBsAg positivity, an average of 4%. With advent of hepatitis B vaccination in the NIP, this percentage would have gone down, but the adult physicians are seeing hepatitis B and its complications. Adolescents are very prone to indulgence in sexual activity and drugs, etc., which make them prone to or vulnerable to hepatitis B infection. So vaccination is for both prevention of horizontal infection as well as perinatal transmission from mother to child. So schedule for adults and adolescents who are not vaccinated or whose status is not known, we need to give 3 doses at 0 month, 1 month, and 6 months. Hepatitis A definitely has seen a very significant shift in epidemiology with more incidence amongst adolescents and young adults. And to our dismay, the disease is more often severe and often acute hepatic failure is attributed to hepatitis A also. So it's not that it's a very mild disease or if we can get away with it. No, it does cause severe complication to the extent of acute hepatic failure. And outbreaks are known to occur. Even these days, we often see sporadic cases or outbreaks also, especially during monsoon, with a lot of adolescents seeing us for hepatitis A. So the recommendations are for 2 kinds of vaccine. One is inactivated, another is live. So 2 doses for inactivated vaccine and 1 dose for live vaccine. If there is a vaccination given, documented, or if there's a disease, there is no need to give vaccine. If you are planning to give a hepatitis A vaccine beyond 10 years, it is good to do hepatitis A antibodies so that we can avoid giving vaccine. But if the cost considerations are there, hepatitis A may be given even without doing serology. Typhoid, again, a very common disease, very prevalent disease occurring throughout the year, and especially more during certain seasons like monsoon. Children aged 5 to 15 years and adolescents are at greatest risk of developing the disease, maybe because of junk food and outside food and a lot of contamination of our drinking water because of the mixing with drainage pipes. Significant numbers lose school days and may need hospitalization. Even adults may have a lot of complications. And we also see recurrent infections and relapses with enteric fever. In spite of all the good antibiotics we have, there is a lot of resistance to some of the groups of antibiotics which are working earlier and they are not working now. And recently, a couple of years back, there was huge epidemic of enteric fever in our neighboring countries, Pakistan, where the pathogen was resistant even to third generation cephaloxins like ceftriaxone. It was only sensitive to azithromycin. And here in India, we are using azithromycin a lot. And we may be facing this problem of ceftriaxone resistant enteric fever, which is happening in some of the higher centers, as we have noticed in our literature. So the recommendation is a single dose of TCV, whatever the age in adolescents and adults. Coming to pneumococcal vaccine, it is one vaccine which is very often discussed in our forums like pediatric forums as well as in physicians forum also. we have two kinds of pneumococcal vaccines. One is polysaccharide and other is conjugated. Time and often we refer to conjugated vaccines. So a sentence about it, that polysaccharide vaccines are less effective. They do not induce memory, whereas when there is a conjugation with a protein, the same vaccines can become very effective with this conjugation, and that is why there is a good development of a lot of conjugated vaccines which are available in our country also, like pneumococcal, typhoid, and we have Hib. So these are the vaccines which are called conjugated vaccines, and they have better memory. They evoke good response on the re-exposure to the pathogen, and of course they give good quality of immunity also. So Streptococcus pneumonia is a common cause of morbidity and mortality across all age groups, especially in very young children and adolescents and older population. It has a spectrum of morbidity because of mucosal as well as what we call as IPD, that is invasive pneumococcal disease. They can cause pneumonia, meningitis in adults or even in susceptible children and adolescents, spontaneous vector peritonitis, sepsis, and all other infections. And with extreme of age, there is high case fatality. We often see older people dying of pneumonia. Maybe there is some underlying comorbidity. Once they get this pneumonia, they succumb to the pneumonia. And in USA, there is a very strong recommendation for pneumococcal vaccines above 65 years. In India, we have PCV13, that is pneumococcal conjugated vaccine 13, which is approved and even recommended by various societies for more than 50 years of age. We'll talk a little bit about more of this schedule later. Let us talk about high-risk individuals who need this vaccine more than any other people. Those who are having immunocompromising conditions or on some medications or having functional asplenia, like say sickle cell disease. Then patients with CSF leaks are very, very potent candidates for infection with Streptococcus pneumonia. Cochlear implants, which are happening quite often now in our state also. Then people with chronic diseases, systemic disease like heart disease, lung disease, or liver disease, and of course diabetes mellitus. So these are high-risk individuals who need to be given pneumococcal vaccine. We routinely use this vaccine for up to 5 years of age, and PCV10, for your knowledge, is now included in our NIP also, that is National Immunization Program. So a costly vaccine is being given free of cost to children up to 5 years. Up to that, this PCV10 which is being used is not approved above 1 year of age, so it is being given before 1 year of age. But that's a very pleasant news for all of us that it is being given to children. But when we talk about adolescents and adults, we need to use PCV13, that is pneumococcal conjugated vaccine. And it can be given up to 18 years for high-risk groups, and it is licensed for use above 50 years, and CDC recommends above 65 years of. So schedule, if there is no prior PCV13 or pneumococcal polysaccharide vaccine, that is PPSV23, which has 23 antigen, apparently looks a great vaccine, but it's a polysaccharide vaccine. So it has its limitation, but it has its place in adolescent and adult immunization against pneumococcal disease in certain situations. So those who have not received any vaccine and who are candidate for PCV, this pneumococcal vaccine, 1 dose of PCV13 should be given, followed by a dose of this polysaccharide vaccine after 1 year, or in some cases early if necessary, but not before 8 weeks of interval between 2 vaccines. So the routine is 1 dose PCV followed by polysaccharide vaccine 1 year later. If received 1 or more doses, there will be situations where some people have already received this PPSV23, then you give 1 dose of PCV13 1 or more years after the last dose of PPSV23. So that's the recommendation. And if you are uncertain about vaccine history, then better to give 1 dose of PCV13. Again, talked about vaccine. Earlier, we pediatricians used to use it anyway. I mean, so many years we have been regularly giving influenza vaccine at least up to 5 years of age. But with this COVID, again, it has come into picture because influenza can complicate any respiratory illness. So influenza, though a viral illness and supposed to be a mild illness, but in certain categories of children and adults and adolescents, it becomes a lethal germ. So there's a wide prevalence amongst adolescents and young adults. A survey of influenza-like illness, that is how the survey is done, mentioned that 55% are more than 15 years of age. So a large percentage of population are getting influenza vaccine, influenza disease. And it can lead to severe morbidity and mortality in extremes of age and in high-risk individuals. The high-risk individuals are same as we had described for pneumococcal disease. So IAP and CDC recommends vaccine for all age groups above 6 months of age. Simply in adult and adolescent age group, it's a simply one-dose schedule. There are issues of serotype, efficacy. There is a issue of serotype mismatch and hemispheric availability of hemisphere-specific vaccine. So these issues are there, but in given situation or for a indication which we have decided to give flu vaccine, I think we should go for the latest available influenza vaccine, and preferably in our part of the country, we should give it pre-monsoon. So maybe May, June is the right time to vaccinate adolescents and adults in our region. Japanese encephalitis, we don't see it much, but there are outbreaks in there are certain belts in our country where it happens in outbreak mode, and it causes a lot of morbidity and mortality and a lot of deaths, and because of the encephalitis. Especially travelers who are traveling to these belts are also prone to Japanese encephalitis. Meningococcal vaccine, not recommended as a routine for all, because we are not an endemic country for meningococcal disease. So it's not recommended routinely for all, but it is definitely recommended for special situations like those who are immunocompromised. And we have in past seen outbreaks of meningococcal disease. So if you are traveling to meningitis belt, especially abroad in sub-Saharan Africa, or if somebody is taking Hajj Yatra, pilgrims, and those students who are going to some countries where it is very prevalent, and it is recommended and it is demanded by the universities to get the vaccination done. So we have 4-valent conjugated vaccines available. There are 2 brands available, and it's again a conjugated vaccine, quadrivalent vaccine. Below 16 years, we give 2 doses 5 years apart. So a booster is given 5 years apart, and above 16 years, only 1 dose is recommended. In children, it's a different schedule from 9 months to 2 years. One particular vaccine can be given in 2 doses, 3 months apart. But apart from that, in children also we give 1 dose. Rabies, again, a very common and a very dreaded fatal disease. And we are all actually susceptible to dog bites with so much of dog population, which outnumber us in many regions. We are all very prone, but young children are especially prone. So post-exposure, as you all know, the initial schedule which we are following earlier was 5 doses, and now WHO has reduced 1 dose. And pre-exposure, I actually recommend to all adults and adolescents where you have a lot of dogs around in your society and community, and if you are going for a walk, it's good to have a pre-exposure prophylaxis. It's very simple. Either you can take 2 doses or 1 dose, 3 doses. The advantage of pre-exposure rabies, anti-rabies vaccine is that if you are bitten by a dog again, you don't have to take that anti-rabies immunoglobulin. It's very costly, and it's very, not a very pleasant thing to get infiltrated in the wound all around. So pre-exposure prophylaxis not only is very cost-effective because it prevents us from having to take anti-rabies immunoglobulin when there is a severe wound, or another advantage is that if you are if you are taken pre-exposure prophylaxis, even after bite, you don't have to take all the 5 or 4 doses series. You take only 2 doses. So these are the advantages. So my recommendation to all of us who are likely to be exposed to dog bite can well do with pre-exposure prophylaxis. Cholera, of course, we don't see much sporadically. Only we saw there is no routine recommendation for cholera vaccine, but endemic areas, yes. And when there are outbreaks, they may be given. There's only 1 oral vaccine available, which is given in 2 doses with 2 weeks apart. Yellow fever, of course, we don't see yellow fever, but if you are traveling to certain countries where it is required, you have to take one dose at least 10 days prior to travel. So these are some of the vaccines which are used in adolescent and adult population. So we have discussed why it is required. We have discussed some of the relevant vaccines. And now we will summarize the whole thing by sharing few more things about this immunization of adolescent and adult. What is the current status? I think there is nothing much happening in this field and much needs to be done. Data as far as the disease burden, epidemiology is concerned is very less. We do not have even data about how many adults and adolescents are vaccinated with some of the vaccines which are meant for them. The National Immunization Program mainly promotes TD, that is tetanus and small diphtheria, and now MMR in campaign mode. Apart from that, Japanese encephalitis only in endemic area, and of course COVID now leads the whole bunch of vaccines. And of course, we have been promoting TD for pregnant women. But in private sector also, although these vaccines are available, the uptake is not to an optimal level. I mean, I can talk about pediatricians where a wonderful vaccine like HPV is available. And most of us actually fail to promote it as much as we should be promoting it. So even those who are affording, I'm not talking about people who are not affording, but there is a huge chunk of our clientele who are actually affording this HPV vaccine, but we fail to inform them, we fail to display in our clinic that these vaccines are available and these are the benefits of this vaccine. So no wonder this lady who got cervical cancer asked. So in her time, this was not available. Now that we have this vaccine, let us try that we can prevent this kind of story where a lady who is going to have become say about 40 or 50-year-old and then get cervical cancer, and they should not blame us that we did not inform that. It's a very wonderful vaccine, very effective vaccine to prevent a cancer. So what is the IAP recommendations for adolescents? MMR, 2 doses, 4 to 8 weeks apart. Hepatitis B, 3 doses, 0, 1, 6 months. Hepatitis A, live vaccine, 1 dose, inactivated 2 doses, 6 months apart. Typhoid PCV, single dose. Maybe in future, there may be recommendation of second dose, but presently a single dose is recommended. Varicella, 2 doses, 4 and 8 weeks apart. Influenza, 1 dose every year for adults and adults. In children up to 9 years, we give 2 doses in the initial part, and then we give those 1 dose only. Japanese encephalitis only in endemic areas, catch up till 18 years of age, 1 dose. Pneumococcal vaccine, as we have already seen, 1 dose of PCV13 and PPSV23 after 8 weeks minimum, and second dose of PPSV23 after 5 years. Rabies, we already seen the schedule. So recommendation for adults, this is to be focused because most of the crowd or audience where we will have physicians, I think they can focus on these slides. It's a summary. TD or TDP every 10 years if no dose in past. And this is for those who have got it earlier. Those who have not been, those who are naive to this can be given 3 doses as TD, Tdap, and then TD, TD, TD. If you cannot afford TD, Tdap, then it's okay to give 3 doses of TD, 0, 1, and 6 months interval. Annual influenza for all, at least older people. Jostler vaccine, of course, not available in India, but very interesting vaccine because it prevents herpes zoster. And it's a very strongly recommended above 65 years of age. It was available in India some time back, but because probably there was poor uptake, it was withdrawn, it's not available. But when it comes to India, I think there should be a good opportunity utilization for use of this vaccine. PCV, strongly recommended above 65 years of age, especially by CDC, that is USA, and 1 dose of PCV13 followed by PPRSV23, 6 to 12 months later, and 1 more dose after 5 years. So this polysaccharide, 1 more dose is given after 5 years. And for high risk, PPV23 is given earlier, that is 8 weeks after the PCV13. There is an interesting observation about recommendation in USA. Earlier, CDC USA was recommended for all adults above 65 years. And now they have switched and they have said that only PPSV23 should be given because there is a change in the epidemiology because of the huge number of, a large population of young children who have been given PCV13 for a very long time. There is a herd immunity which has developed. So they have observed that the incidence of pneumococcal disease is actually not growing anymore in adult population. So now they don't recommend it, compulsory PCV13 for adults above 65 years of age. In India, the scenario is different. PCV was being used only in private sector so far for only few years, about 8-10 years. And of course, being a very costly vaccine, it was not taken well by a large chunk of population. So we cannot say that because of young infant immunization with PCV13, our adults are well protected. No, that will take some time. It will take about a decade to happen so that vaccinating young children with conjugated vaccine will protect adult population also. So in India, I think we should go with the recommendation of vaccinating adults above 50 years, and especially those who are at high risk. HPV, we have seen that it can be given up to 45 years. So even women who have born children, I mean, we also pediatricians are often approached by these mothers who would willingly take these 3 doses of HPV at 0, 2, and 6 months. So obstetrician is the onus of on the obstetricians to recommend this vaccine to mothers who are coming to them, because there is an evidence that HPV still protects the sexually active women up to 45 years of age. TCV 1 dose up to 45 years of age. MMR in a situation where we saw some of the indications, 2 doses 4 to 8 weeks apart. Varicella again as catch-up 4 to 8 weeks apart. Hepatitis B 3 doses 0, 1, 6 months. Hepatitis 2 doses for live, 2 doses for inactivated, and for live 1 dose. Hepatitis A and hepatitis B for chronic liver disease. This is one single indication which the adult physicians should keep in mind. And I often see advised by physicians for patients who have been having chronic liver disease, they are advised about hepatitis C and hepatitis B catch-up vaccination. One thing which we all should remember that live vaccines are to be avoided in immunocompromised host. So this is one slide which summarizes the cost of these vaccines. Tdap, that is our Boostrix, 1200 to 1300. TD is only 20 rupees. Hepatitis B only 80 rupees. Rabies vaccines are quite okay, 350 to 400. PCV is costly, 4,000 or more now. The price is going to increase. Meningococcal 4,000 to 5,000. Varicella 2,000 to 2,200. Typhoid 1,800 to 2,200. Hepatitis A 1,600 to 2,000. Yellow fever 2,250. Japanese 700. Influenza 2,000, and HPV. This 4-valent is 3,600 and 9-valent is 11,000. So having looked at all this, let us have a reflection on this, that we have realized that immunizing adults and adolescents is very important, but we are not moving very fast in that direction. So the way forward is the adult and adolescent medicine practitioners, we pediatricians and adolescent medicine practitioners, the pediatricians, internists, family physicians, we all need to be updated. We need to be updated about availability of these vaccines, their indications, and we must keep on offering these vaccines to those at least who can afford them, make them aware at least. Whether to give a vaccine or not is an individual's decision, but our patients always look forward to us for our guidance. So we need to grab opportunities in the OPD and IPD. For example, a patient, 60-year-old who is suffering from pneumonia is recovering, a chat can be established with him, the need for vaccine with influenza vaccines or pneumococcal vaccines. So we need to grab these opportunities. And we as healthcare providers should protect ourselves. Often in our conferences, the speaker would ask the audience, how many of you pediatricians have taken the vaccines? And unfortunately, very few hands are raised. Gradually, the awareness is building amongst pediatricians also, and they have started vaccinating themselves. If you ask me, yes, I always take annual flu. I already taken PCV. I already taken Tdap. I already taken pre-exposure prophylaxis to rabies also. So we can also set examples to others to follow. So where do I get all this information? For adolescents in India, our organization, that is Indian Academy of Pediatrics, routinely publishes guidelines through what we call as Immunization Committee, now known as ACVIP, that is Advisory Committee for Vaccination and Immunization Practice. And I happen to be a member of that committee a few years back. For adults in India, there are various organizations which bring out guidelines, like API, that is Association of Physicians of India, brought out a book. The second edition was in 2014. IMA had a publication in 2018 titled as Live Courses. And then other societies like Chase Society of India, Diabetes Association, Geriatric Society of India, they all come out with some vaccines with main emphasis on pneumococcal vaccine. In USA, for all age group, there is one single committee, and that is ACIP, Advisory Committee on Immunization, which is part of the well-known CDC, that is Center for Disease Control. So these are the various guidelines. This information I have shared because some of you who got interested may visit their websites and get a lot of information on CDC also. So friends, it is time for questions, and being the speaker, I have the first privilege of asking a question, and that may be playing in all of your mind, those who are not pediatricians, as to why a pediatrician is talking about adult immunization. Friends, we are not encroaching into your domain. It's just the fact that we as pediatricians are trained for immunization. We study vaccinology, and there are huge books on vaccinology, numbering up to 3,000 pages book. So we are trained, and of course, we practice immunization day in and day out. You can say a large chunk of our practice is vaccinology. So it's time for shooting more questions, and thanks for the opportunity and attention. Thank you all. I'll stop sharing my screen.
So thank you so much, sir, for giving us such a lucid talk on such an important topic, that is adolescent and adult immunization. It will definitely bring a difference into our daily clinical practice. Now I invite Dr. Samir Shah sir and Dr. Ashutosh Singh Rathod to ask questions from the chat box.
Before that, I have read one question. Hepatitis A live. No, it is not 2 doses. It was in one of the slides, it was mentioned correctly. In the last slide, I also realized that there was a mistake. Hepatitis A live is 1 dose and inactivated 2 doses. So that was a mistake in the typing. Yes, now you can shoot questions.
Right. So as usually, lucid talk on your one of the favorite topic, I can say, and it's definitely a topic for the utilization for all of the, not only for pediatrician, including each and every person who is practicing the medicine has nowadays interest in the vaccinology because of the COVID. So few questions are there. One is the Pneumovax vaccine, H1N1 vaccine is good in COVID-19. Should I it taken in the gap of how many months?
Usually it is recommended that after COVID vaccine 1 month you should avoid other vaccines. Otherwise it can be, theoretically there is no harm actually in taking any other vaccine. For the information of general audience, any inactivated vaccine can be given at any interval without interfering with the immune response. It's about only live vaccines, say hepatitis A live vaccine or your MMR vaccines, which are live vaccines. There you have to keep a gap of 4 weeks between 2 live vaccines. Otherwise, with inactivated vaccine, there is no such gap required.
Schedule for the 9-valent HPV vaccine.
It is same actually. I have not used it. I am afraid of using it. I have not yet offered to any patient, but I believe it is the same.
It was asked that suppose someone was already vaccinated with 4-valent vaccine, then should we take 9-valent, and if yes, then what will be the schedule?
Again, as I heard from one of the speakers, I have not studied this subject very well. It's a recent launch, but it was said that you need to give all the renew series of HPV-19 if you really want the whole protection, because it was that this 4-valent would protect against other serotypes also. Then 9 was not required at all. So to prove that also, they recommend a full revision of the schedule.
How many doses for a typhoid conjugated vaccine? Because the medical representative recommended 2 doses.
as I said, the recommendation, official recommendation is 1 dose only, because the studies done so far, so good sero conversion, even after 5-6 years of study of the first vaccine which was launched in India. So officially only 1 dose is recommended, but there are experts who believe that in future, because they think that this seroconversion is not a real correlate of protection against entry, and that's why they recommend 2nd dose also, but officially only 1 dose is recommended. So it's a matter of debate.
What is the immunity duration after pre-exposure rabies vaccination? Someone has taken pre-exposure rabies vaccination.
Up to 3 months, you can avoid any vaccine. After 3 months of that, you can give 2 doses of vaccine if you are taken
No, sir.
pre-exposure.
They are asking what is the immunity you get after a pre-exposure rabies vaccination. Suppose a child has come and taken all the.
That is what I am saying. No, 3 months. 3 months should be the time beyond which we should revaccinate.
Okay.
Dr. Bhupendra Kapare elaborated one whole scenario. One child has completed a post-exposure prophylaxis with rabies, immunoglobulin, and ARV of all 5 doses. Now, if child come back with a dog bite again, say after 3 months, 6 months, 9 months, and 1 year, what will be the strategy?
I have not read about it, but I would give 2 doses as a, we consider this as a pre-exposure prophylaxis. So we have to give 2 doses. We don't have to give more doses, and no RIG, of course.
Will be then again the immunoglobulin will be required or not?
No, because when you are giving pre-exposure, you are giving only 2 or 3 doses, and still you don't give RIG. That's the biggest advantage. So whether you have taken vaccine as a pre-exposure or post-exposure, you have taken more than 3 doses. So there is no need for RIG again. Never. Never.
Sir, you take on Gardasil newly launched.
Any recommendation from chronic diseases of neurology, endocrinology, liver, hemat, even in like IBD? So in adult
liver, renal, hemato, yes. All these are indications. For which vaccine we are talking?
That was a general question.
List of vaccinations for that.
Yes, any chronic illness makes you less immune to certain diseases, and so the official list doesn't mention about IBD, but it does, if the patient on IBD is on some immunosuppression, I would like to go for these vaccines, especially pneumococcal vaccine. Otherwise, in my list, I had mentioned about liver, renal, hematology, cardiac chronic disease, etc. I had already mentioned in that.
Yes, sir. So someone is interested in knowing about dengue and malaria vaccine.
Dengue vaccine had developed and was to come in India, but then the vaccine which we were to import turned out to be more lethal. It did not work with children, and it used to cause more mortality in children. So at present, no. Malaria vaccine again in pipeline, but we don't see anything ready as yet.
The last question. What all vaccines are recommended in a splenectomy patient?
In a splenectomy patient, all the vaccines which I described as conjugated vaccines, like your meningitis vaccine, your Hib vaccine. Hib we give in children, but adults also who have been splenectomized, they can benefit with Hib vaccine, that is Haemophilus influenzae, then Enteric and pneumococcal. These are the 4 or 5 vaccines which need to be given to any person who is to undergo splenectomy. So before splenectomy, preferably this should be given. I think the recommendation is at least 2 weeks before splenectomy.
Over to Bhupendra sir. Thank you, sir.
So thank you so much, Dr. Samita and Dr. Ashutosh Singh Rathod, to cover all the questions written into the chat box. Now I invite Secretary of Academy of Pediatrics,
one more question,
Dr. Bhavish Kanaba, to give vote of thanks. Okay.
One more question.
Sir, any role of chickenpox?
Any role of?
Chickenpox vaccine, post chickenpox.
No, as I mentioned that once you get chickenpox, you don't have to give vaccine because it gives you lifelong immunity. So once there is a documented history of chickenpox, but what happens in practice is that parents would say that okay, but you are not sure whether that was a HFMD, that is hand-foot-mouth disease, or some pyoderma or some other eruption. So there has to be a documented evidence that some pediatrician or a clinician has seen and written that this is chickenpox only. If that is there, then you don't have to give a vaccine again. Somebody had asked about hepatitis E. So hepatitis E, we don't have vaccine for hepatitis E.
So here we have completed the list of questions written into the chat box. Now I invite Secretary of Academy of Pediatrics, Vadodara, Dr. Kavish Kanada, to give vote of thanks. Bye-bye, you need to unmute yourself.
On behalf of Academy of Pediatrics, Vadodara, I would like to thank Indian Medical Association, Vadodara branch, and Vadodara Academic Adolescent Health Academy for arranging this nice session. I also like to thank Dr. Satish Pandya sir for the lucid and such informative topic lecture, and I also thanking all participants which are in such large number for attending this session. And last but not least, I would also thanking DG Shield for arranging this, for providing the platform and arranging this informative session.
Thank you.
Thank you.
Thank you, sir.
Thank you all. Thank you all.
Thank you, sir.
So we end the meeting here.
Yes, sir.
Thank you.
Please end the meeting.